Jordan Colbert, a public health registered dietitian candidate at University of North Carolina, Chapel Hill. Thank you for being here to listen to my case study submitted for the completion of my clinical dietetic internship with Sarasota Memorial Healthcare System. The patient of focus in this presentation is a middle-aged man admitted to the main hospital for COPD exacerbation. Our RD team received a consult to provide diabetes education, and I was really looking forward to answering questions and helping him reach his nutrition goals. However, when my preceptor and I went to see him, I found that he was agitated, not feeling well, and not open to education at the time. I was initially frustrated because in the ideal dietetic student universe, every patient would be enthusiastic about what they can do to improve their health and nutrition. But unfortunately, this is the real world. So after some thought, I realized I had learned a lot from this patient experience and decided to present this story for my case study. This patient is a 60-year-old Caucasian male, English speaking. The electronic medical records indicate that he identifies as Roman Catholic and is single. It is presumed that he lives alone, and there is no emergency contact person listed on his chart. His most recent employment is stated to be at Wendy's and 7-Eleven. Records indicate that he pays for his medical expenses out of pocket, suggesting that he does not have insurance. Some known health risk behaviors. The patient reports that he used to smoke heavily, but has now reduced his cigarette smoking to 2 cigarettes per day. He also confirms intermittent marijuana use and occasional alcohol consumption. His primary means of transportation is a motorcycle. The patient's medical history is listed here with most notable points in bolded font. He has had 10 documented visits to Sarasota Memorial Healthcare System in the past year, multiple of these for COPD exacerbation. COPD, or chronic obstructive pulmonary disease, refers to diseases that block airflow and cause breathing-related problems. Smoking is a primary risk factor for COPD in the United States. This patient also had a recent motor vehicle accident, and it resulted in a traumatic hemothorax requiring chest tube placement, which likely worsened his already existing COPD. The patient also has a history of colitis in his medical records. This information is important to keep in mind from the nutritional perspective, as dietary recommendations should be modified depending on whether he's experiencing an active flare or not. Unfortunately, we did not have time to discuss his colitis experience during our visit. Finally, the patient has had a recent cholecystectomy, gallbladder removal. While this is one of the most common procedures performed in the United States, I was not previously aware of recent data showing that people with cholecystectomy are at an increased risk of developing insulin resistance and diabetes. The course of admission. So the course of the patient, we will review this visit totaled 10 days. The reason for his admission was shortness of breath with coughing, wheezing, and sputum production. He was admitted with hypoxia. His oxygen was at 84% on room air, despite the use of his rescue inhaler. Upon admission, his glucose was slightly elevated at 114 milligrams per deciliter, and his glycated hemoglobin, or A1C, was 6.1%, which puts him in the pre-diabetic range. His white blood cell count was also slightly elevated, and another notable finding was that he was missing many teeth from his top row. This is a summary of the treatments and services this patient received. He received various therapies, including imaging services, respiratory therapies, drug therapies, and a diabetes consult from both a clinical dietitian and a diabetes educator. Of note in his drug therapies, he was on prednisone and antibiotics. The RD team received a consult request reading consistent carb education as patient was found to have new onset diabetes. An assessment of his labs showed an A1C in the pre-diabetes range, so it wasn't in fact a diabetes diagnosis. He was also shown to have a gradual increase in blood sugar levels, which was likely due to the steroids, per the provider's note. Further research also suggests that his elevated A1C levels could have been contributed to by his recent gallbladder removal and repeated COPD exacerbations. I noted his low albumin. However, this is not an indication of malnutrition and was most likely correlated to his inflammatory status. He was on a regular diet. In previous charts, he had a history of being on a cardiac diet with low cholesterol, low saturated fat, and sodium restriction. However, on this admission, he's provided that I'm on a regular diet and allowed for double portions at meals. During the visit with this patient, he was apparently agitated and voiced complaints about inconsistency in his meals. I realized that this distraction would likely impair how he receives any education and counseling, and changing his diet order to a consistent carb diet, no matter how beneficial it might be to his blood sugars in the long run, would definitely cause problems for the patient. After performing the comparative standards, it became apparent that this patient was consuming well over 100% of his energy needs. He was eating all of his food, ordering things like hamburgers and French fries. And while the calculations showed he needed somewhere around 2,700, allowing for the upper range of that need in consideration of his COPD, he was averaging around 4,000 calories per day, which is definitely excessive. An anthropometrical analysis on the right of this slide showed that he was 121% of his ideal body weight, with nearly a 4% increase in his weight over the past 6 months. I kept this in mind during the diagnosis, and since there were kind of multiple things going on, I chose 2 PES statements. The first was excessive energy intake related to increased appetite from steroid medications, as evidenced by energy intake of greater than 100% of estimated energy needs, and intake of large food portions with high caloric density. The second PES statement is related to the fact that we received the diabetes nutrition education consult in the first place. So this statement reads, food and nutrition knowledge deficit related to lack of or limited prior diabetes related nutrition, as evidenced by a patient with no prior need for diabetes nutrition education and recent increase in blood sugars in A1C. I also noted that the patient verbalized an incomplete understanding of starchy versus non-starchy vegetables, and the patient was not ready for lifestyle changes, as he stated that it was the steroids only, not lifestyle, that was affecting his blood sugars. This patient's excess caloric intake struck me as an important diagnosis to note for any future RD consultation. Excess weight gain would likely worsen his insulin resistance. Also, the excess food intake is likely influenced by his medications, particularly his steroids, which is important for the medical team to keep track of. The second PES statement was, again, focused on the education consult we received and his elevated A1C level. Nutritional intervention for diabetes control would be more of a long-term focus for this patient as he becomes more open to the information. At this visit, again, he was not open to it. My goal for this patient was to encourage him to choose more vegetables during his stay at SMH, provided him with education in the form of handouts from the Nutrition Care Manual. The handouts explain what carbohydrate servings look like and the difference between starchy versus non-starchy vegetables. Due to his dissatisfaction with the hospital food service, we kept him on a regular diet. Ideally, we could have added a diet order for consistent carbohydrates to help moderate his intake. For this reason, we recommended the provider in future RDs to switching to a consistent carbohydrate diet order when his blood glucose exceeds 180 milligrams per deciliter. Key points for monitoring include 1, intake, monitor for increased vegetable selections at meal times. 2, weight trends, monitor for his possible weight gain due to excess energy intake secondary to steroid medications. And 3, biochemical, monitor his blood glucose levels to assist in glycemic control throughout the admission. Evaluating the patient consultation, it appeared to me that he was not ready for lifestyle changes. He was reluctant to accept new information or to consider that his elevated A1C could be in any way due to lifestyle. He received a visit from the diabetes educator the following day. There is no evidence to show that either consult led to a change in ordering habits at meal times, at least during this day. His glucose levels continued to climb, which was not surprising considering his continued dependence on steroids and no other modifications. Prognosis and progress. From a medical perspective, the patient did not feel better despite evidence of improvement, his oxygen saturation did improve. He just reported to not feel an improvement. He initially refused to go home with supplemental oxygen due to fears about how it would impact his quality of life. However, he ended up not being able to leave without it. His oxygen saturation dropped to the 80s again after just a few minutes of walking. From a nutritional prognosis, the patient will likely be back in the hospital with another exacerbation of COPD. Research shows that patients with elevated blood glucose levels are at an increased risk of experiencing future COPD exacerbations. His blood sugars may go down as he finishes with his steroid dose. However, he is at an increased risk for developing type 2 diabetes, considering his dietary choices and lack of ability to exercise secondary to his shortness of breath. Also, considering recent evidence of the association between cholecystectomies and diabetes risk, this patient will definitely benefit from nutrition counseling if he becomes receptive to it. To review, the patient is a middle-aged man admitted for COPD exacerbation. Our RD team received a consult to provide education on consistent carb diet for a patient with new onset diabetes. Through this encounter, I learned one of the most valuable lessons a dietitian can learn, that sometimes patients are just not ready to discuss nutrition goals and may not be open to learning new information. Although I had every intention to spend this visit on education and counseling for nutritional management of blood sugars, this patient was agitated during the visit and unreceptive. Our conversation revealed gaps in his nutrition knowledge and his eating behaviors during his stay, including burgers, french fries, and sodas, were not helpful for any long-term goals of blood sugar management. Through this experience, I feel I've become more capable of identifying patients who are at the pre-contemplative stage of change and how to work with them. If I could do this experience over, I would still have provided the diabetes education handout. However, I would not have even attempted to discuss it during this visit. Instead, I would have spent more time asking this patient questions about his understanding of his diagnoses. I also learned about the strong impact of steroids on appetite and blood sugar levels. For a patient with COPD, frequent exacerbations mean frequent steroid use. These patients may definitely benefit from nutrition counseling far before displaying any biochemical indication of need. Finally, I learned about this fascinating connection between gallbladder removals and increased risk of insulin resistance. This is new research, and researchers are still unclear about the physiology leading to this association, but it provides a rationale for connecting cholecystectomy patients with dietitians for preventative nutrition care. Thank you for your time today. If you have any questions, feel free to reach out, and I appreciate you listening to the case study.